Today we are going to discuss biostatistics and ENT for USMLE. If you like this type of content, make sure to like the video and subscribe to the channel for future videos. There's a newly screening test. It has a cutoff of 0.75. However, a randomized control trial assessing its efficacy concluded that a cutoff of 0.5 would be more suitable for screening the US population. Lowering the cutoff will have one of the next consequences: decreased negative predictive value, increased negative predictive value, increased positive predictive value, and increased specificity. Please let me know your answer in the chat box. Okay. So, the answer is A. We have a decreased negative predictive value. Now, for what concerns the cutoffs, we want to lower the cutoff if we have a screening test. When lowering the cutoff, we decrease the false negative and increase the false positives. This will lead to a higher negative predictive value, as the negative predictive values is defined by true negative divided by true negative plus false negatives, and the false negatives decrease. And also we will have a higher sensitivity due to the fact that, once again, sensitivity is true positive divided by true positive plus false negative, where false negatives decrease. On the other hand, lowering the cutoff will lower the positive predictive value and specificity. The positive predictive value is true positives divided by true positive plus false positives. Lowering the cutoff will mean that we have a greater amount of false positives. Specificity is defined as true negative divided by true negative plus false positives. Once again, the true negatives here will decrease substantially, leading to a decrease in specificity. In regards to increasing the cutoff, the method is used for confirmatory tests. This will lead to higher PPV and specificity due to decrease in false positives, and a lower NPV and sensitivity due to an increase in false negatives. Okay. Are there any questions on the topic? Hello, Missy Hyatt. Pleased to meet you. Okay, then let's pursue further. A PhD student comes to his supervisor stating that he achieved an extremely low standard deviation for his test. The supervisor is not pleased to see that the demand on measuring real values was not achieved. What could be said about the test? A. It has low levels of systematic errors. B. The test does not give consistent results. C. The test consists of good measurements. Or D. It has high statistical power. Please write your answer in the chat box. Okay, we have a D. Miss Hyatt, could you tell us why you chose D? Precision is defined as the reproducibility and result consistency. On the other hand, accuracy is the ability to obtain results that are close to the real values. Low values of precisions are seen with random errors. On the other hand, systematic errors lower the accuracy. What is the effect of a high precision rate in a test? It lowers the standard deviation and it increases statistical power as seen here. This is a two-way relationship, meaning that decreasing standard deviation will lead to increased precision, as well as increasing precision will lead to decreasing standard deviation. The same can be told about statistical power. Let's discuss the other answers. If we have a test that has low levels of systematic errors, then we have a high accuracy, not precision. If the test does not give consistent results, then we have low precision. And if the test consists of good measurements, it is probably an accurate test. What we see in this clinical vignette is the fact that having a low standard deviation means that the PhD student made a highly precise test. In contrast, the supervisor wanted a test that measures real values, meaning an accurate test. Having a high in precision test but low in accuracy means that we have high statistical power and low standard deviation due to precision. Okay, are there any questions on this vignette? Parth and Hyatt, do you have any questions, or would you like to proceed with the next clinical vignette? Okay, thanks. Then let's proceed with the next one. We have a 25-year-old we have a 25-year-old who drowned 5 days ago. When he was brought to the emergency department, the chest X-ray showed bilateral hazy infiltrates with a PaO2 to FaO2 less than 300. The ICU doctor decided to put him on mechanical ventilation. On today's rounds, a discussion takes place on whether to wean off the patient from mechanical ventilation. What is the indication for this decision? A. The patient is on low PEP with adequate oxygenation. B. The patient has respiratory acidosis. C. the peripheral oxygen saturation is 90%, or D, there is no more water in the lungs on the CT scan. Let me know your answers in the chat box. Also, please present the argument for your choice. The answer indeed is A. Now, this patient had ARDS. What are the main causes of ARDS? They are sepsis, trauma, pancreatitis, massive blood transfusions, pneumonia aspiration, inhaled toxins, especially in burns, and drowning. How is ARDS managed? Well, ARDS is managed with a low volume PEEP to avoid overdistension and mechanical trauma inside the alveoli. The goal oxygenation is a peripheral oxygen concentration of greater than 88% or a partial pressure of the oxygen greater than 55. What are the indications to stop the mechanical ventilation for patients with ARDS? The first one is if the patient passes a spontaneous breathing test. Another reason for weaning off is adequate oxygenation with low PEEP, as in the case of this patient. A third case is if oxygen supplementation can be easily achieved without the support of mechanical ventilation. For instance, the patient receives oxygen via oxygen mask. Okay, Dr. Deepak, Parth, or Maya, do you have any questions on this clinical vignette? Okay, let's go further then. So, if you want to support this channel and its growth, then consider donating on Patreon. This is the link. I will leave it in the chat box. Also, if you are interested in exploring other educational videos for USMLE, this is a playlist that will greatly enhance your ability to answer USMLE questions. Now, let's go further to the next clinical vignette. A physician designs a new randomized control trial to test his hypothesis that drinking ethanol causes a reduced libido. What is the unsuitable criterion to support the causality relationship? A. Alcohol consumption precedes symptoms of reduced libido. B. The more alcohol is consumed, the less libido a patient has. C. Another alcohol was found to cause reduced libido. Or D. There are no animal studies showing reduced libido after ethanol consumption. Let me know your answer in the chat box. Miss Hyatt, Perth, as well as Dr. Deepak. So we have a C. Other perspectives? Are there any other perspectives? there is a D. No, a C. Okay, let us see. Missy Hyatt, what is your take on this question? Okay, let's discuss the answers. So the question focuses on the Bradford-Hill criteria to provide limited support on causality relationships. A states that alcohol consumption precedes symptoms of reduced libido. This is one of the Bradford-Hill criterion that states, that there is a temporal relationship in which the cause precedes the effect. So it is correct. Therefore, it is a suitable criterion to support the causality relationship. B. The more alcohol is consumed, the less libido a patient has. Another Bradford-Hill criterion is the biological gradient. This means that the more exposure to the risk factor the patient has, the greater the effect is. Once again, this is a suitable criterion, not an unsuitable one. C. Another alcohol was found to cause reduced libido. This is another Bradford-Hill criteria that states the analogous relationship. For instance, we have a cause and effect relationship between a similar situation and our cause and effect. Lastly, D. There are no animal studies showing reduced libido after ethanol consumption. This is the unsuitable criterion due to the fact that it violates one of the Bradford-Hill criteria, namely experiment. This means that you have to have an experiment in vitro or on animal studies that shows the relationship between the cause and effect. So the answer was D. Let's talk about Bradford-Hill criteria and review them. There are 9 of them. Firstly, a biological gradient, as we discussed. The greater the effect observed, the greater exposure. This is the dose-response relationship. The strength. Although association is not equal with correlation, the greater the strength, the greater the chance for causality. The experiment criterion, as we discussed previously, states that the correlation was found in animal or in vitro experiments. The temporal relationship means that exposure to the risk factor preceded the effect. The analogy consists of a cause and effect that are similar to another cause and effect. Plausibility. There is a mechanism explaining the relationship between the cause and the effect. Another criterion is consistency. This means that the observation has been repetitively observed for the effect after the patient was exposed to the risk factor. The coherence means that there is no conflict between the cause and effect in the scientific consensus. And specificity, the greater the specificity of the cause to the effect, the greater the chance for correlation. Okay, Dr. Deepa and Parth, do you have any questions on these criteria? Okay, Dr. Deepak, the criteria will be sent through the weekly newsletter so that you can refer to the criteria themselves. The next question. A 35-year-old patient suffers a motor vehicle accident. On admission in the ER, he can barely say anything due to a lump in the carotid triangle. On palpation, the lump is mobile, and on auscultation, there is a swirling sound. What is the best next step? A. Incision and drainage. B. Surgical intervention. C. Endotracheal intubation. Or D. Compression. Perf and Deepak, please let me know your answers in the chat box. So we have a C. Indeed, the answer is C. The patient has an expanding hematoma which compresses the trachea. Per primary survey indications, the first thing that we secure is the airway. What are the indications for endotracheal intubation? Firstly, the patient could have structural airway damage, blood in the airway, gurgling with noisy breathing, subcutaneous emphysema. Secondly, there might be an airway compression, expanding neck hematoma, as in this case. Another indication for endotracheal intubation is a GCS less than 8. Last indication for endotracheal intubation and airway securization is thermal or inhalation injury. Okay, are there okay. Now, an assembled hospital team creates a fishbone diagram to analyze an event. Which method of medical error analysis is this? A. Failure mode and effect analysis, or B. Root cause analysis? Let me know your answer in the chat box and why you figure that that is the right answer. Okay, so we have two B's. Please let me know why do you think root cause analysis is the one to choose for a fishbone diagram. Okay. Parth is right, as well as Dr. Deepak. The answer is B. To have a short recap, a fishbone diagram is used to trace every root cause of an event. Failure mode and effect diagram anticipates all the ways a procedure might fail. Then it establishes which failure has the highest probability to occur and prepares for it in a prospective manner. On the other hand, root cause analysis is an analysis of every aspect that contributed to an adverse event, so it is retrospective. Therefore, we use a fishbone diagram to look retrospectively to ways in which the process failed. Okay, are there any questions on this clinical vignette? Perth, Dr. Deepak. Okay. Then, you can subscribe to the channel if you want to see more of this content, and you can provide some feedback on this form to improve the quality of these live streams. Otherwise, I'm grateful for your participation. I'm grateful for your participation, and we'll see you in the next one. Thank you, Parth, and thank you, Dr. Deepak. Please let me know your feedback through the form, and please let other students that want to prepare for USMLE to know about this channel. Have a nice day ahead.